Good evening to all of you. I must thank all of you for being part of this program being conducted by the WASC as a part of its campaign Save a Limb, Save a Life. At the outset, I thank our beloved VSI President Professor Unnikrishnan for all the encouragement he has given to us for this program. I equally thank Dr. R.C. Srikumar, who has been a constant source of inspiration for all the WASC activities. I also congratulate all those who have been behind the scenes to make this program a reality. Going on to my topic proper, endovascular therapies has to replace open surgery. What exactly do we mean by angioplasty? Angioplasty is a technique of percutaneous access into one's blood vessel and using special hardware like guide wires, a atherosclerotic plaque is traversed and using a balloon the lesion is plastered to the vessel wall, creating a new channel for the blood flow to resume. Over years, the pattern of vascular diseases have changed. When I did my post-graduation in surgery, we used to see more of aortoiliac and femoropopliteal diseases. But over time, the incidence of diabetes has increased and the disease pattern has shifted from the more proximal segments to the more distal segments of tibial and pedal arteries. This came with more challenges because arteries in these beds were more calcific and makes it equally challenging for the vascular surgeon to deal with. What is the aim of treatment in any patient with critical limb ischemia? As we have already heard, this is to achieve is at least a single artery inflow to the foot, which will in turn leads to healing of patient's ischemic ulcer. Previously, all surgeons were experts in open surgeries, and in 1995 to 2000 period, a lot of studies, a lot of work has gone into different types of limb bypasses, and success rate of limb bypasses were to the tune of 70% limb salvage rates at 5 years. But over time, people thought of lesser invasive techniques, and vascular surgeons all over the world thought about developing and innovating endovascular treatment for such peripheral and difficult peripheral arterial diseases. But then they were actually uh, faced with certain difficulties. Most important being positive hardware. Initially, all peripheral interventions were done with dedicated coronary wires. Lack of expertise. There was no specialty which focused on patients with peripheral arterial disease. And so we as surgeons had to take the help of cardiologists and interventional radiologists to help us out to improve the blood flow to patients' foot. But over time, vascular surgery became a well-defined specialty and then changes began to happen. By 2000, newer hardware had come in, dedicated wires and balloons for peripheral arterial disease. This actually opened the floodgates to the management of peripheral arterial disease, and the results of peripheral angioplasties started improving dramatically. When we talk about endovascular therapy or peripheral angioplasty, there are three approaches. One is antegrade approach, where we approach the lesion from above and we pass a guide wire through the plaque, and then the lesion is angioplasty and to create a new channel. When the antegrade approach is not feasible, there's another technique where we approach the lesion from below. In this cartoon, you can see a dorsalis pedis artery has been accessed, and then in this real life picture, we access patient's posterior tibial artery, and then a wire is passed to cross the lesion from below, and this wire is captured from a catheter coming from above to finish the procedure. There's another technique called subintimal angioplasty, where instead of going through the lesion, we tend to pass the wire between the plaque in and create a new intimomedial plane, and thereby creating an entirely new channel devoid of any disease. And this is said to have more longevity than the traditional endovascular procedures. In my next part of presentation, I will try to answer some questions which is very pertinent or which is very important to the techniques of peripheral angioplasty. First question is, can all lesions be treated by endovascular techniques? Well, the basic guideline or the basic guideline to this question is the task grading. Task is Transatlantic Society consensus grading, which classified arterial lesions based on the length and complexity of the lesion. Grade A being a less complex lesion with a shorter occlusions or stenosis, and grade task D being the complex lesions which are longer in length. Task A is usually dealt by endovascular techniques, whereas task D is usually dealt by open surgical techniques. When we discuss management of peripheral arterial disease, we divide patients' arterial tree into three segments. One is aortoiliac, femoropopliteal, and infrapopliteal. I'll just take you through a few examples uh, of the interventions done in these vascular beds. This is a patient with total occlusion of infrarenal aorta and right iliac artery. This patient would have otherwise needed an aortofemoral bypass, but this has been tackled by endovascular technique using two stents in the aortic bifurcation with good results. Another patient with a long lesion of the left common iliac artery, which has been tackled by endovascular technique using a balloon expandable stent with a fairly good result. When you come to femoropopliteal segment, this is a patient with a occlusion of distal femoral artery with reformation in the popliteal artery, and with just a plain balloon angioplasty without using a stent, he has a very good result. Again, this is an example of patient whom we did a subintimal angioplasty for a long femoral occlusion. Uh, the wire is traversed across the lesion. Actually, wire is not passed straight. It is passed as a loop across the lesion. We reach the opposite side of the lesion and check whether we are back into the true lumen. And then after angioplasty, you can see nicely open superficial femoral artery, here again without use of any stents. Coming to intrapopliteal disease, which is the most challenging aspect of treating peripheral vascular disease. Again, complex lesions, simple lesions like these can be treated by straightforward angioplasty techniques, and also complex lesions like this where involving multiple tibial vessels can be treated with peripheral angioplasty techniques. And then came the concept of endovascular first treatment, wherein vascular surgeons and interventionists thought that why not treat all these patients with the endovascular technique, and only if endovascular fails, you subject the patient to open surgery. Well, this concept has gained acceptance all over the world, and in our practice also, we now tend to treat all our patients with endovascular first, and only in most situations, only when endovascular treatment fails, we subject the patient to open bypass surgery. What are the factors that favor endovascular or open surgery or surgery or endovascular? It is the risk of surgery. Higher the surgical risk, the preference goes for endovascular procedures. Lower the life expectancy, the preference goes for endovascular procedures. When the tissue loss is very extensive, surgery is preferred over endovascular. And sometimes multi-level disease and diffuse vascular disease are some situations where endovascular has got definite edge over open bypass. As in this case, you can see a 55-year-old male who's undergone CABG with an ischemic leg ulcer. The angiogram is showing diffuse disease with no definite target vessel in the foot, and it's very difficult to find a target vessel for bypass in this patient. So this patient could be easily managed by endovascular technique where you can open the whole femoral popliteal and anterior tibial artery down to dorsalis pedis. These are some situations where endovascular techniques have got some advantage over open surgical techniques. Another question which we need to answer and people often ask is that, are use of stents mandatory in peripheral vascular interventions? Actually, the answer is in aortoiliac segment, stents are almost always used. In femoropopliteal segment, stents are seldom used, and most of the time we could get away with plain balloon angioplasty. In an intrapopliteal segment, stents are almost never used. But there are some situation where you need to use specialized stents and specialized balloons to prolong the the patency of endovascular intervention in femoropopliteal and intrapopliteal segment, about which Dr. Vimal will talk after, we will make a presentation after this talk. Next pertinent question is it possible to decide if the endovascular treatment is most ideal for this given patient, or should we suggest surgery or endovascular? That's a big dilemma in the mind of any vascular surgeon or any interventionalist. Till date, we did not have any guideline to answer this question, but last year, Society for Vascular Surgery with other world societies brought out a guideline which is called Global Vascular Guidelines. Based on global vascular guideline, there is something called this grid, which is similar to the TNM staging or something for breast cancer, where on one side you see we have what is called glass staging, which refers to anatomical complexity of the blood vessel, of the occlusion of the arterial tree. On the lower side, you have got what is called limb severity, or what is called a Wi-Fi staging for diabetic foot, ischemic diabetic foot ulcers. When these two grades are charted, or one on y-axis, one on x-axis, you can fairly predict any patient who comes in this green box is a candidate for open surgery. Any patients who fall in the red box do not need any revascularization. Any patients who fall into yellow box, actually they are more suitable candidates for endovascular treatments. So that's a new staging system called GLASS, and which is based on Wi-Fi staging of diabetic foot ischemic and diabetic foot ulcers. What are the results of endovascular intervention? Are they really great, or are they very inferior to surgery? If you ask me, in aorta iliac segment, the results of endovascular is almost equivalent to open surgical procedures. But when it comes to femoral-popliteal segment, surgical treatments have got better patency, but actually the limb salvage rates are equal with surgery or endovascular, especially when you consider patients with critical limb ischemia. In infrapopliteal segments also, surgery has got better patency, but endovascular can give equal limb salvage rates at par with open surgical techniques. So patients who are not really fit for open surgery are actually ideal and the best candidates for endovascular treatment. Coming to most pertinent question of this talk, who should ideally be performing endovascular procedures for patients with peripheral vascular disease? As I told in my talk before, in ester years when vascular surgery specialty was not there, there are not many vascular surgeons. Many of our cardiology and radiology colleagues used to help surgeons perform procedures related to peripheral vascular tree, and to get blood flowing across, treating lesions and getting things through. But then over years, vascular surgery has evolved as a specialty, a specialist who can actually do open surgery as well as do interventional procedures for this subset of patients. There have been studies and publications about this topic, and world over, the vascular surgeons have been involved in the management, to a larger extent, in the management of treating patients with critical limb ischemia. And as you can see in this graph, the number of procedures being done by vascular surgeons have dramatically increased and have given consistently good results, because any interventional procedures has to have a backup of a vascular surgeon, because without an surgical backup, and proper intervention cannot be performed. And this paper clearly addresses this issue and says, comes to a conclusion that critical limb ischemia, when treated by a vascular specialist, gives a better result than being treated by any other specialist. Now, coming to the key question of this talk: has endovascular replaced open surgery? In our practice in India, or in Kerala, or in a place like Calicut where I do my practice, when I started my practice in 2007, we did more of bypass surgeries, and angioplasties were almost zero. As you can see, in 2008, I hardly did an angioplasty. But over 10 years, as you can see, in 2019, we did just 6 limb bypass surgeries, whereas we did 65 peripheral angioplasties. So the graph has hugely tilted from open surgery to uh, angioplasties. So, like world over, the trend in India and in our state is actually more towards angioplasty. That clearly indicates that uh, even though peripheral angioplasty has not completely replaced open surgery, but to a larger extent, it has indeed replaced open bypass procedures. So, to conclude, endovascular therapy is feasible in most patients with peripheral arterial disease, but a judicious decision based on various patient factors, including cost, which is the most important factor in our patient population, should be made by a specialist trained to treat patients with vascular disease to improve outcomes. I hope I have given you a bird's eye view of endovascular management of peripheral arterial disease, and thank you all for a very patient hearing. Thank you.